CDD, control of diarrheal diseases. This is a program that was set by the WHO, World Health Organization, to deal with cases of diarrhea in children, which is very common and has a high morbidity and mortality. It kills a lot of infants and young children every year. And the main objective of this program is to deal with the main killer in diarrheal diseases, in infectious diarrheal diseases, which is not the infection itself, but the dehydration, and to a lesser extent the malnutrition. So the main aim in this program is to decrease mortality and morbidity in children, and it proved to be very successful. What is diarrhea? Diarrhea, as defined by WHO, is stool that contains more water than normal. Of course, we previously were defining diarrhea as frequent bowel motion, but this proved to be incorrect. It is the frequency and the consistency of the stool, but of course the consistency is more important, because frequency is not reliable, as we have what is called the rule of 1 per 10 to 10 per 1, which means that the bowel function of children may differ from one to another, which means that if the consistency is good, some children may put out bowel motion once per 10 days, or some children may do that 10 times per 1 day, and all are normal if the consistency is good and if they have no real symptoms of diarrhea or constipation. Why are we so concerned about diarrhea in children? Because it is the leading cause of death, especially in developing countries, which form the highest percentage of diarrhea in children. About 3.2 million deaths per year in those less than 5 years of age is registered throughout the world every year, with an average of 3.3 episodes of diarrhea per year, which may reach even to 9 episodes per year. In some areas, death mostly occurs in the first 2 years of life, as children in this age are usually more vulnerable to get diarrhea and to die, because they cannot complain, they cannot express their needs or their suffering, like pain or diarrhea, or their need to drink water and so on. Not like adults. The main causes of death are dehydration, which is usually severe and very rapid in children. Also malnutrition, especially in persistent diarrhea and dysentery, and serious superimposed infection. Diarrhea also presents an economic burden on the developing countries, which includes bed occupancy. About 1/3 of hospital beds in some countries is occupied by patients with diarrhea, and you can imagine how many diseases we have, hundreds of diseases, but 1/3 of all diseases is occupied regarding the beds by children with diarrhea. And this is a depletion of the resources that are allocated for health in each country. We can use these resources in the absence of diarrhea for the treatment and prevention of other diseases. Also, the expenses of intravenous fluid, treatment like antibiotics and other ineffective drugs. And why we say ineffective, we will come to this in a minute. Types of diarrhea. We have three main types of diarrhea regarding this program, which is the CDD, control of diarrheal diseases. First, acute watery, which lasts for less than 14 days, sometimes associated with vomiting. The other type is dysentery, which is diarrhea plus visible blood in the feces, associated with rapid weight loss due to anorexia. The third type is persistent diarrhea, which is diarrhea that lasts more than 14 days with episodes of watery diarrhea or dysentery associated with dehydration and malnutrition. These are the three types which are included in the CDD program. The other type, which is chronic diarrhea, is not included in the CDD program because it's not due to infection. This program only deals with diarrhea due to infection, which we call infectious diarrhea. Transmission is usually promoted by specific behaviors, like failing to breastfeed exclusively for the first 4 to 6 months of life. And when we say exclusively, we mean that only water and nothing but water is going to enter the GIT of the newborn infant. Previously, we were telling the mothers to give water to her child, especially during summer, because he needs water as we do. But later on, scientific research proved that the breast milk itself contains different percentage of water according to the season. For example, in the summer it may reach up to 80 or 90% of the constituents of the breast milk, I mean water. And in the winter, of course, it will be less. So we need not give water to the child. And if we can do that, I mean the mothers can do that properly, the exclusive breastfeeding, then we can guarantee that nothing like infection will happen to this child, of course, presuming that they follow the other needed hygienic and sanitation measures. Second, using infant feeding bottles. And we know there is nothing good in the feeding bottle. There is only bacteria. And we know that there is a very good media for bacteria in the nipple of the feeding bottles. Why? Because the processed artificial milk usually contains sugar to make it more sweet to attract the child, and milk which contains protein and lipid, and this combination is very attractive to the flies, which usually carry the bacteria in their hands and legs and come to the nipple and put it on the nipple. And no matter how much we clean the nipple, it will stay not safe, because there is a hole that leaks milk and will attract the flies and the bacteria. So we better avoid it, because it is the main source of infection at this age. And you know that the feeding bottle is generally not good for the child, but some families believe that it is better because the child uh, is not getting satisfied, still hungry and crying. But as a matter of fact, it's mostly the mother that does that for cosmetic reason for her breast, and this is not good. We must educate the people, especially mothers, about that, because once the child start to take bottles in their feeding, then they will hardly transform to breastfeeding. Once they stay for 2 or 3 weeks on the bottle feeding, we will find great difficulty in bringing them again to breast. Why? Because the nipple of the bottle is very large, larger than the nipple of the mother, so it will fill the mouth of the child. And in this phase, which we call the oral phase for children at this age, when they know nothing, they cannot think, they feel only, feel the nipple which is very large and fill their mouth, so they feel more secure about their feeding. At the same time, the whole the whole of the nipple is large and passing more milk than the nipple of the mother. And of course, as we said, the milk is very sweet, not like the milk of the mother. So uh, after all these points, I think the child will be more attracted and more connected to bottle feeding, and he will not accept to go back to breast feeding. Storing cooked food at room temperature, and we know that room temperature sometimes is high, as we see in our country, so it will also form a good media for bacteria. Using drinking water contaminated with fecal bacteria, this is especially in hard to reach areas that where there is no purification or chlorination of water, and people usually throw or dispose their feces in the river, and then they drink from the same river which contains contaminated water when there is infection in the area, and this will be transmitted to the child. Failing to wash hands after defecation, disposing of feces, or before handling food. And you may be surprised if you know that more than 60% of our people do not wash their hands after defecation or before meals or before preparing meals for the child. And we have a difficult job in educating those people. Etiology of diarrhea, according to occurrence, to prevalence, the most common cause is rotavirus. Rotavirus forms more than 70% of the infections of diarrhea in children. And this is a very important point. Why? Because this shows that the use of antibiotics in children with diarrhea is irrational and is wrong and is not ethical, because sometimes it's very dangerous and there's no need for it, because antibiotics do not work against viruses. So why are we giving it? Unfortunately, some doctors do that because they are inefficient. They are either not sure that this is viral, or they are afraid that this patient may consult another doctor if they don't give them a lot of medicines. Enterotoxigenic Escherichia coli is second cause of infection. Also Shigella, where there is of course fever and toxic appearance of the child. Campylobacter jejuni, Entaminobacter histolytica, which is common in Iraq and maybe come may come before Shigella, also Vibrio cholerae and Salmonella. The main two dangerous killers in diarrhea in children are dehydration and malnutrition. We'll come to dehydration later, but now we summarize the causes of malnutrition in three main points so that will be easier for you to memorize. First, either reduce the intake or increase the output due to calorie loss or problems in absorption. Reduce food intake usually because of anorexia, which is common in any acute disease, especially in dysentery. Also, vomiting that will make the mother scared to do any attempt at feeding. She will not give any food because she's afraid that the child will vomit, and she thinks that vomiting is not good or is dangerous. She doesn't understand that vomiting is a defense mechanism of the GIT, which feels that there is something abnormal, and so it contracts to get rid of this invader, which is the bacteria or the virus, to put it out. So vomiting is not a dangerous sign, it's just the defense mechanism. Withholding of food based on traditional beliefs about treatment of diarrhea, because most mothers have the traditional belief that during diarrhea we need to raise the bowel because giving food, as they think, to the child will exhaust the GIT, and of course this is not correct. We should educate them about that. Giving food will reduce the nutrient value. Also, to raise the bowel, usually they give soup or gruel or anything which is light. Why? To raise the bowel. And this is okay, it's not wrong, but this is not food. We should label it under the category of fluid. We will give it, but as a fluid, and we need to give food, proper food, to the child to strengthen his immunity and compensate for his needs through the loss. Decreased absorption of nutrients due to damage to the absorptive villi in the intestine, and also due to disaccharidase deficiency owing to impaired production of enzymes by the damaged villas, may lead to malabsorption of disaccharide sugar, especially lactose. Also, reduced internal concentration of bile acids and rapid transit of food through the GIT, leaving an insufficient time for digestion and absorption. And this usually occurs because the GIT feels, as we said, that there is something abnormal, there is an invader, which is the bacteria or the virus. So the GIT wants to get rid, to defend itself through severe contraction, just to throw this invader out. So usually the GIT in the normal situation contracts very slowly in a harmonic way to give time for the villas to absorb the food and the fluid. But when there is an invader, and as we said, as a defense mechanism, GIT will contract very strongly and rapidly, so the food will pass very quickly, and this will leave no sufficient time for digestion and the third cause is increased nutrition requirements due to metabolic demands with fever, also damaged appetite, and the need to replace serum protein lost through the damaged mucosa, as in dysentery. The main points in the prevention of diarrhea is to oppose the points that we previously mentioned that facilitate the transmission of diarrhea. So here we give only breast milk for the first 4 to 6 months of life, exclusive breastfeeding. Avoid using infant feeding bottles. Improve practices related to preparation and storage of weaning food, because some people, as we said, are not very alert about the type of weaning food which should be nutritive and should compensate for the loss of breast milk so that it will give good immunity for the child. Also using clean water for drinking and washing hands and safe disposing of feces, including those of infants. There are also some measures that strengthen the defense, like continue to breastfeed for at least 2 years of life. Also improving nutritional status by improving nutritive value and increased amount of weaning food. Well, sometimes the weaning food is not valid with low nutritive value, and this is related to the traditional habits and sometimes to ignorance. Some people, when do the weaning, they give nothing to the child but some bread and maybe vegetables, and this is not correct. We must replace the high nutritive value of milk by also high nutritive uh, value food. They also found that immunization against measles decrease the chance of infection with diarrhea, and we don't know why nobody does, but they found that in population with good immunization of measles, they have usually low rate of diarrhea, in contrary to population with low immunization against measles. Now we come to the program which is set by WHO, as we said. It's called CDD, stands for Control of Diarrheal Diseases. They found that diarrheal diseases in the past decades cost a lot of lives of children. Millions of children die because of diarrhea, and millions of dollars or billions uh, are lost due to the unnecessary antibiotics or sometimes to fluid and bed occupancy and all other needs and health services. So they put a program that depends mostly on 2 points: assessment of the condition of the child with diarrhea, to set his needs, and to set the type of treatment that he will take. This is the first point, assessment. The second point is treatment with oral rehydration solution, which is available, not expensive, very practical, and very good to the child. It's superior to the IV fluid, and we will come to this program as first. Assessment. We have 6 points in the assessment of the child, any child with diarrhea: general condition, eye, mouth, thirst, tears, and pinched skin. The general condition is either well, alert, irritable, restless, or lethargic and congested. And as you see here, the three columns are low and the bottom of the columns labeled as A, B, and C. By A, we mean diarrhea with no dehydration, which is just newly happened and there was no time for the child to develop uh, dehydration, or it is not that severe to develop dehydration, not yet. Maybe within few hours he will get dehydration. So we call it diarrhea with no dehydration. B, diarrhea with some dehydration, and C, diarrhea with severe dehydration. So in the first column, the child usually well and alert regarding the general condition, while in B, diarrhea or some dehydration, he will become irritable, restless, because he will feel something wrong and he needs water, and he will have electrolyte disturbances, and so he will become irritable because he doesn't know what is wrong, and so he's restless. In the third stage, which is severe, the child will be very tired of this irritability and will lose more fluid and electrolytes, so he will become lethargic and sleepy and sometimes even unconscious. Regarding the eye, In A it is normal, in B it is sunken, and in C it is very sunken. The mouth either moist, dry, or very dry. And of course you are following with me. That is A is the diarrhea with no dehydration, B diarrhea with some dehydration, and C diarrhea with severe dehydration. And we are going quickly to make it easy for you. Thirst, not thirsty in A with no dehydration, while with some dehydration he drinks eagerly because he feels that he needs much water. He takes the jar from you or the glass of water and maybe even wet himself because he wants to drink very eagerly. And in C, as far as he's lethargic or sleepy, he cannot drink. Tears either present or absent, and pinch the skin of the abdomen. And I believe that you know this maneuver. When you pinch the skin of the abdomen of the child, it either goes back slowly or quickly in A, and slowly in B, and very slowly in C. Well, there is an important point here. How can we label the child as A, B, C easily without uh, any overlapping? Of course we can't. Why? Because the child usually doesn't go by the book, which means that he doesn't go by column. He may be in the phase of transmission from A to B or from B to C, so that there may be some signs from A and some signs from B, or some signs from B and some signs from C. So this overlapping may cause a confusion that we cannot assess or decide whether it is A or B, or whether it is B or C. Of course, there is no overlapping between A and C. It is either between A and B or B and C. So to settle that and solve this problem, they put what they call the star signs. And as you see here, there are some stars in the first general condition, and in the thirst, and in the pinched skin. In B and C we have stars, which means that if two star signs are found in the same child, then we will label the condition as the column of these stars. For example, if this child is irritable and restless with normal eye, moist mouth, but drinks eagerly, or the skin goes back slowly, then he will be labeled as B, diarrhea of some dehydration. Or if he is irritable, restless, but he cannot drink and the skin goes very slowly, these two last signs are within C, so he will be labeled as C. And why is that? Because the differences here in the general condition, differences are very clear. For example, irritability and restlessness is very different, the opposite of being lethargic or unconscious. At the same time, drinks eagerly is the opposite to cannot drink. It is not like, for example, the eye sunken or very sunken. Sometimes you cannot differentiate between sunken and very sunken, or dry and very dry, or absent tear and absent tear. And that's why we put these star signs. So after this stage, when we do a proper assessment, we will know that this child either under A category, diarrhea with no dehydration, B, diarrhea with some dehydration, or C, diarrhea with severe dehydration, because on this assessment will the treatment depend. So the child will fall either under the category of A, no dehydration, B, some dehydration, C, severe dehydration. The treatment here will be, if A, the treatment will be at home, if B, at primary healthcare center, and if C, at hospital. Well, in A, we send the mother with her child home and teach her, we give her oral hydration solution and teach her how to use it. Of course, we have two types of oral hydration solution, two packets, either dissolved in 500 ml or 1 liter. So we tell the mother that the first step is to boil the water to sterilize it, and then after it becomes warm, then we put, or she puts, the oral hydrate solution powder and shake it until it dissolves in water, and then give it to her child by small glass or spoon. If he is young, less than 2 years, then she should use the spoon, or if he is more than 2 years, then she puts the oral hydrate solution in a cup and give it to him by sips. Well, if the child is less than 2 years, we tell her to keep on breastfeeding because it's very important as a source of fluid and food. If the child is more than 2 years, then we tell her to give as much fluid as she can. Well, the fluid is usually and most commonly water. She gives water, of course, sterilized water, as much as she can because this will compensate the water loss. She can also give any sort of fluid, but preferably salty fluid, not sweet, because sweet fluid will change the osmolarity of the intestine. And it's preferable that the fluid is warm, of course. Uh, well, here an important point again about the oral hydration solution. Uh, the taste of ORS is not very nice because it is not sweet, so the child will not accept it easily. But he can take it anyway with some care and with some patience. Maybe the mother can sing to her child and give it to him slowly. Sometimes if she gives it quickly or rapidly, then there might be some vomiting because of rapid distension of the stomach. So the mother may get panic, so we tell her that if vomiting happens, don't fear of that. Just stop giving the ORS for 10 or 15 minutes and then re-give it, but slowly and less frequently so the child can accept it without vomiting. The constituents of the oral hydration solution is glucose 20 gram and sodium chloride 3.5 gram, sodium bicarb 2.5, and potassium chloride 1.5. They may add citrate to it to give it flavor, or we can add any home remedies. And mentioning the home remedies, we can also give fluid like the fluid of rice as home remedies, or any fluid in the house, but we avoid the sweetened fluid like Coca-Cola or Pepsi-Cola and these soft drinks because it's not good for the child. Sometimes it's harmful. So we give the oral hydration solution, the warm oral hydration solution that will compensate the fluid loss and electrolyte loss. And of course, they discovered the oral hydration solution in 1947 during the epidemic of cholera in Egypt, and it was very effective. So we gave it to the child to help him even in his distension of the GIT, the intestine, stomach and intestine will resume its normal situation after the contraction due to infection, and the warmness of the fluid will also help the absorption in the intestine. Well, this is about the oral rehydration. We tell the mother to keep giving the child as much as possible, even if she stays for the whole night, so that the child will be improved rapidly. And this is a good characteristic of children, that they deteriorate rapidly, but uh, going back and cure very rapidly. Well, how much do we give? We tell her to give 100 to 200 ml ORS or fluid or both after each loose motion, according to age, of course. If less than 2 years, then we give 50 to 100 ml. If more than 2 years, then we give 100 to 200 ml. And how we measure the mils? Of course, the small cup of tea, which we call East tea can, is usually contains 50 cc or ml, and the glass of water, the ordinary one that we use at home, is usually 200 cc. So we can measure it that way. So now we know the important points, that we keep on breastfeeding, or we give fluid, and we increase food intake. It is not correct to give less food to the child with diarrhea. We should give more food than normal to compensate for his loss. So we give at least 4 to 5 meals per day, which should be normal meals, normal food, not fluid diet. Not fluid diet. This doesn't mean that fluid diet is not good. It is very good. We should give it, but we label it as fluid. We put it under the category of fluid supplements, not food supplements. So we give fluid diet, and we give in addition 4 to 5 meals per day, and we can add a spoon of oil, preferably olive oil, to use it by the child for energy, so that he will not lose the nutritive value of the food. The food should be not roughage, because this will increase the contractility of the intestine, not diluted, and not sweet. So we know now about breastfeeding, about fluid, and about food intake. And the last point here is to tell the mother to come back in certain conditions. If the child doesn't get better, if vomiting happens or increases, if diarrhea increases, if the child develops fever, or if blood appears with stool, we tell her that these are not good signs regarding the prognosis, and she may come. If any of these signs appear, she may come again for consultation to reassess the condition of the child. This is regarding category A, which is diarrhea with no dehydration and treatment at home. If there is diarrhea with some dehydration, which is category B, then we better treat the child at primary healthcare center. We have special units in each primary healthcare center, which is called the oral hydration unit. We have fire source, and we have bottles and glasses, and we have ORS, and we can make it, we can process it, and we can give it to the child in front of the mother, so that she will learn how to give it at home. And we give it according to the laws, and after we give it for 2 or 3 hours, then we reassess the child to see if he or she is still in B according to the signs of the previous slide. Then we repeat the treatment of B oral hydration solution at BHCC, or if he goes back to A, that's diarrhea with no dehydration, and this is usual, of course, if we did the process in a good way and successfully, then he will move back to A, and so we will give the mother oral hydration solution, and we will give her all the instructions that we just talked about, and let her go home and come back only in certain conditions. If after the assessment we found that he's deteriorating and going rapidly to C, then we send him by the ambulance to the hospital, where they will give him intravenous fluid. Because why intravenous fluid? We usually avoid intravenous fluid, especially for children. Always give oral hydration if the child can drink, but if he is in category C and is unconscious or lethargic, then he cannot drink, so we move to intravenous fluid. We calculate it according to the weight loss, whether if it is simple or moderate weight loss, then it will be 5 to 7%, or could be 10% if it is severe. We multiply by 100, so the outcome will be something like 1.5 pints or 2 pints. We give it the first third of this amount very rapidly during the first half an hour, and then we give the other 2/3 during 2 hours, the 2 hours after that. Plus, don't forget to move to oral rehydration solution as soon as you can. Once the child is alert again and can drink, then please stop the intravenous and go to oral rehydration solution, because this will compensate it rapidly and safely. And then of course we do the assessment. When we do the assessment again, we usually see that the child is going back to B, so we send him back to primary healthcare center, or maybe to A, and we send him back to home and following the usual instructions. Finally, there are two very important points in the application of CDD. First, we never use antibiotics unless we have certain conditions, like if there's fever, we think of malaria, especially if there's malaria in the region, which is endemic. If there's fever and blood, then we think of shigellosis, when the child comes very toxic with high fever and mucus with stool. If the stools are watery, then we look for cholera in the area. If there is blood with stool, which is called dysentery, and treatment of shigellosis failed, then we think of parasite amoebiasis, because as you know, we have two types of dysentery, two conditions where we have visible blood with the feces. Shigellosis, which is called bacterial dysentery, and in this case we have, as we said, high fever, toxic child with the mucus and pus with the stool, and amoebiasis, which is parasitic dysentery. If diarrhea lasted more than 14 days, then we think of giardiasis. So apart from these conditions, we never give antibiotics because it's useless, because as we said at the beginning of the lecture, most of the infection, more than 70% of the diarrhea in children, caused by viruses. So antibiotics have no place here. Besides, it might be harmful because of its side effects without giving any benefit. This is the first important point. The other important point is never give anti-diarrheal, antispasmodic, or anti-emetic drugs, because these drugs will act by certain mechanisms through decreasing the motility of the intestine, which we don't want, because this motility will cause more contraction and will cause shedding of the microorganism to the outside, and this is important because this will decrease the period of the infection. And if we give the antispasmodic, then the motility will decrease, the contraction will decrease, and there will be prolongation of the period of the infection. Besides, these drugs proved to have very dangerous side effects, especially neurological one, permanent damage. It may cause permanent damage to the neurological system, especially among children less than 7 years of age. So it is now forbidden in all countries of the world. Well, the last point is, why do we adopt CDD? It is to decrease morbidity and mortality, of course, in the first step. And this is done in an easy, rapid way with less facilities, less cost, and less suffering of the families, and less burden on the health system of the country, with the participation, important participation of all health workers and the family themselves. Thank you.